all of what Coleman has said is where we were at with, well, what can be done differently for children before they get into that crisis service. And we looked around a little bit and we came across a new programme that was starting in the UK. This has been going on for about 3 years, is it? 3 or 4 years? And it's about universal mental health supports teams in schools, in primary schools. And we kind of monitored their implementation and how they were working and some of the results they were getting. And we thought it was well worth investigating more in terms of a model that could suit Ireland. At the same time, we were also aware of a model that was happening in Ireland in a school in Limerick, in Corpus Christi School in Moyross. And we have a parent, Sonia, with us today from that school who's going to speak on the panel. But they, out of the need in their area, had created a similar model without knowing about the UK model. So we kind of, I suppose, want to present some of the solutions, some of the hope that we think could absolutely start to fill that gap for children and that early intervention and prevention. So I'm really pleased that Sarah has come over from the UK. She arrived yesterday evening in Dublin, and only the second time you've been here, after seeing her dad play squash a number of years ago in Dublin. So you're very welcome to Dublin. Sarah is the clinical lead in the mental health support team in schools in the Dorset Healthcare Trust, which was one of the early pilots of this scheme. So Sarah's going to tell us how it works in the UK. So thank you very much, Sarah.
Hi, thank you so much for having me. It's really strange being at something face-to-face after 2 years of Zoom and hiding behind your screen and things, so please bear with. So, as Anya said, I'm Sarah. I'm one of the clinical leads from Dorset, and my background is in occupational therapy. So I trained as an occupational therapist 20 years ago, so been a fair while. And my family background is in education. So my parents were both teachers, then they were head teachers. My sister's a teacher, my brother-in-law's a teacher. So I said, I'm never going to work in schools. And I've spent the last 18 years working in schools, just in a different guise. So a lot of the stuff I'm going to talk around is around our southwest delivery. So that covers the 7 kind of counties within the southwest. So Dorset, we're kind of on the far reach of that. And then we've obviously got Cornwall, Devon, Somerset, Wiltshire, Gloucester and the Bristol area. So a lot of the stats and the information will be around not just for Dorset, but for that whole kind of area. So where did we come from? So in 2017, there was a green paper brought out by the government around transforming children's mental health provision. Similarly to what Coleman was saying, we've had huge issues in CAMHS for a long time in the UK around kind of increasing access, backlogs, huge waiting lists, you know, you name it, we've been there. But this green paper was around setting out increasing and improving mental health support for children and young people. And it focuses very much on that early intervention and prevention, especially in and around the links to schools. So the proposal that was given back in 2017 was around creating a brand new mental health workforce of community-based mental health support teams. Every school and every college will have a designated mental health lead, which is now in its sort of first year of rollout because there was a bit of delay because of COVID. And we're working towards a 4-week wait time for NHS children to be seen within the NHS. So we work to a 4-week wait within our service. So we have 3 core functions. So the first is evidence-based interventions for mild to moderate mental health issues. And we use outcome measures to do that, and I'll show you some paired outcomes towards the end. And we do our sessions either individually, so that's face-to-face or online, through group work or through parenting, and that can be individual or group work. And the type of children that we're working with at that are the children who wouldn't meet a normal CAMHS criteria. So it sounds a bit sort of flippant, but almost like you're almost anxious is the worried wells, the children who are just starting to be on that cusp of school refusal, so they might just be struggling to get into lessons a little bit more or come into school, or might be a little bit more clingy to mum at the school gates, you know, the children that are like limpets that you have to kind of peel off and hand over. So that's the children that we're trying to target. We also support the designated mental health lead in developing what we call the whole school approach. So that is just embedding mental health and wellbeing as part of the school ethos. And that can be through delivering whole class interventions, and I'll talk a little bit more about some of those that we've been doing. Because actually what we recognise is that, you know, children need to be taught about how to manage their anxiety. We all have anxiety. We all have mental health. We all have good days, bad days. What we don't want to do, and similar to what Coleman was saying earlier, is pathologicalise it and turn it into a medical issue. We want to normalise it and say, do you know what? It's okay to have a bit of an off day. It's okay to feel a little bit sad when your hamster's died. It's all right to feel upset when your best friend has decided to go off and play with somebody else for the day. You know, those are normal feelings, and we need to get away from that good or bad being happy or sad. Happy and sad aren't opposites of each other. Happy is an emotion, sad is emotion, and we need to all feel both. It's part of what makes us feel human. So actually, by getting away from that drive of, you know, I must always feel happy, which then puts a lot of pressure on young people. I must be happy, I must do well. Well, actually, you're not going to do well at absolutely everything you do. Everyone's got their own strengths and weaknesses, and that's what we need to focus on and build that resilience and get children to understand that it's okay not to be good, bad, happy, sad all of the time. And the other part is around signposting and giving timely advice. So a lot of our work is around signposting to other services, because mental health services are not the right place for every single child. You know, if somebody's had a bereavement, we've got some fantastic bereavement counsellors and charities that work specifically with that. That's not a mental health condition. That's somebody feeling really sad because gran's died or their parents died, or, you know, we've had young people who've really struggled with, you know, their pet dogs that they've had for decades, and they've really struggled with that loss. That's not a mental health problem. That's normal, you know. So actually, by signposting, say, why don't you go and just talk to somebody about it in a different way? We're not medicalising it. So our ambition is to have nationally 25% of MHSTs and 25% of all of the schools by 25. Our Southwest offer will be 50% in 2024. So that just shows the impact and the way our commissioners within that Southwest region have taken us on board. So just to kind of give a bit of an idea of what our teams look like. So each service has a clinical lead. So that's for example, myself. We have a team lead, a supervisor practitioner, and 4 what we call education mental health practitioners. Now, those people are trained, so we recruit them specifically, so we're not taking from a CAMS workforce, we're not taking from other services, because I think historically what's always happened is you take one from another, it's like a game of chess, and actually your workforce doesn't expand. So the training that we provide is it's a postgrad diploma in mental health practice in education. So they go away for a year. Majority have been things like TAs, psychology graduates, but we have had other professions, because actually we want to bring in a new and exciting workforce. And they go away for 12 months, and they do 3 months solid at university to start with, and then they come out and work on practice in placement with us within the teams. And then over the year, they become qualified. And actually what's really exciting is that those the EMHPs and our wellbeing practitioners are actually going to be accredited with one of the psychological societies shortly. So we've been working really closely with the BPS, the British Psychological Society, and the BACP, which is the Association of Counselling and Psychology, to actually get them accredited so that they can be registered, approved practitioners with that national body background, as opposed to just being, a clinician within a mental health team. So they will be, so when you look up on the register, you'll be able to see that they've fulfilled the requirements for registration. And again, that supervising is really important. So they get supervised every week in group and for individual. And that's from people who've got that psychology background and will kind of really focus that in. So in the Southwest, we're going to have 58 teams across the Southwest with 232 trained EMHPs, covering 50% by the end of next year. And that will reach 435,000 children in our area. So actually, for a relatively cheap team, we're hitting an awful lot of young people, and we're preventing those young people going on into specialist services. And just to give a bit on the national picture, in 21 to 22, 26% of pupils or learners, and this is primary and secondary, I wasn't able to kind of get it down, but 2.4 million children across the UK will have had potentially some intervention. We've got 4,789 schools and colleges participated last year. And by the end of this year, we're going to have reached 36% of all of those young people nationally. So again, that just shows the drive and the infrastructure that we're putting in. So in terms of some of our benefits, we've had really positive responses from children and young people and our schools. Historically, we've always had a bit of a backlash with our education colleagues. You know, I come from a CAMS background. There was always a sense of, oh, we're not going to bother referring people. The waits are too long. But then, of course, children reach crisis point, and then it's like, well, why didn't anyone do anything sooner? You're kind of like, well, you didn't refer them back then. Oh, yeah, well, we thought they'd be longer. But actually, by working together, we've really increased that communication. For us in Dorset, in a 6-month period in 21 to 22, we've prevented 647 young people going into specialist CAM services by giving them that universal interventions in school. The accessibility is huge, so the schools know they can phone us. So rather than sending referrals to inappropriate places, schools will phone us up and say, I've got this young person, I'm a bit worried about them, what do we do? And then we'll talk it through with them, and we'll help find the right treatment and the right services and the right support at the time that they need it. And the delivery of what we call wellbeing workshops to whole classes, those don't require a referral, we just book those in. So, for example, what Coleman was saying about friendships, we had a group of Year 5 pupils, which I think, if I've worked it out rightly, is your 4th year, possibly. So they'd be like your 8, 9-year-olds who are having a real problem with friendships. So rather than talking to those 3 young people, we said, well, why don't we do a whole workshop to all of your Year 5s in your school? So, and several other schools got wind of this, and so we've now delivered this workshop around friendships and problem solving to, I think, 7 Year 5 classes across our area, which is nearly 200 kids who've now gone, oh, actually, and the schools have noticed the impact of that. We're also currently working on our transition programme for our Year 6s who move up into secondary. So I think that's probably your fifth year. Last year, we did 379 workshops to all of those children, targeting over 600 kids who were moving up. We did 3 half-hour workshops at the end of Year 6 and a 1-hour in Year 7 when they'd moved. So we did the preparation for moving, how to manage it. It's okay to be a bit scared. You know, it's a big school. We got maps. We put out little things so they could work out where they had to go on day 1, how to find people, who to ask. And then we saw them again in Year 7 when they'd moved and just revisited some of that. And again, what we've noticed, and we've done other workshops as well around sort of just general anxiety. In one school, it was a secondary school, we had no referrals from that year group for the next 3 months because of the interventions that we'd put in place to the whole classes. So again, that just shows the impact of actually doing that early help and prevention. We have challenges. Our team in Dorset came into existence in February 2020, 6 weeks before all the schools in the UK closed. So we were a 2-year pilot, and despite setting up and rolling out during COVID, when we had no schools, we actually managed to get schools on board with remote working. We had children who were vulnerable still in schools who we were able to work with. So we were able to get our trainees through their qualifications during COVID, to the point that the CCG within the first year went, wow, this is working. So the CCG is our commissioning group who basically give us the money. Went, actually, we're not going to wait for you to have 2 years of pilot. We just want this now, and we're going to give you another 4 teams in September next year. And we kind of went, okay. So, they've kind of really seen the benefit. I think one of the difficulties has been around getting training cases and young people at the right level. Schools, because they kind of have always had the CAM stuff, were throwing us all of the high-risk young people. And we had to do a really big piece of work to say, actually, no, this is the level we need because it's prevention, it's early help, it's getting in there at the point before they reach that. Because if we can target these young people, so just as Coleman was saying earlier as well, if we get in early, you prevent things happening in the future and you can build resilience. So again, yeah, filling gaps. That's not our remit. We've got a very clear remit. So I'm just going to show a clip, if I can hopefully get it to work. And I'm going to take it to 6:23. So this is...
The support from the mental health support team has been really beneficial in our school. For example, obviously it's increased teacher awareness of some of the mental health needs of the young people that we work with. I know that one of the children, for example, was really struggling with anxiety, and they worked with her and her mum every week for about 6 weeks, and that child is now coming into school, whereas before they were really struggling to get them in. And she's even talked about how positive it was herself, and is able to articulate how much she appreciated the work that Ruth did, and is also now attending some sort of drop-ins just to do sort of check-ins with her. So it's made a really big difference.
It's little things like our students are very anxious, and you know that they're enjoying something when they come up and ask about it, or enjoying is maybe the wrong word. They're finding it helpful and useful to them, and they want it to continue, because they come up and they'll say, what time's my appointment? And it's like, well, you know what time your appointment is, because Nat gives you a slip, and she texts you to just kind of double check things. So why are you asking me? Because you do know. It's just they want you to know that they're still doing it. And certainly with 2 students, I've seen a massive increase in the way that they would interact with me. They're a bit, so maybe a bit nervy to start with, and you say, oh, I've got this thing. Do you think this you might want to engage? Okay. And then I'm like, chatting about, I don't ask any personal questions, but is it like, oh, has it gone all right? And yeah, it's been brilliant. So actually just the positivity from quite a low group of students has been really massive to see. And I'm not saying, if I said to them, oh, grade yourself on the mental health, they're all going to go 10, 10, 10, but it's definitely, you can see the shift up, and in their demeanour, you can see them just that little bit more confident.
So that clip just is from 2 of our teachers in the Bristol area, just giving their feedback on how they found it within their own schools. And I think, that's the feedback we're getting. Schools are noticing a difference. Schools feel supported. They're feeling like they're not having to sort of scattergun referrals because they don't know where to go. They can come directly to us, talk to us, and we can help find that support for the young person. We've got some amazing third-party organisations and charities that we work alongside. We've got workers who've got a specific, sexual assault and trauma centre. So actually, if there's been any incidents like that, we can refer to them. They're the specialists in that area. We've got our Mosaic service, which is our bereavement service, so we can work with them. We've got organisations such as called the Horse Course, which offers equine-assisted therapy to young people. And if we feel that actually talking isn't going to be the right thing, we might refer them on to their services. So we've got lots of other agencies that we know about that schools or a particular teacher might not. So actually that joint working, and it's exactly what we're saying, that interagency working is massive. We work really closely with our colleagues in social care and local authority. So actually if we've got a young person whose social needs are a nightmare, then we can bring in our early help colleagues to kind of go in and work with the parents and work with the young people within the home. Because actually what young people want is they want to be worked with where they are. Working in CAMS, we had high DNA rates because parents have to take time out of work. It can, they have to bring them to the appointment. That can take half a day out of your working week, potentially. And if you're seeing somebody every week, that's a lot of time for employers to be kind of giving up as parents. Going to the schools, working in the schools, the children just have to kind of come from their classroom to us. And actually, we're getting much better kind of access rates because of that, because children want to come to us. We've even had young people who've asked to come back to us. I mean, that never happened in CAMS. I had an email from a girl who was aged 13 saying, I found it really helpful the first time. Something's gone a little bit wrong. Can I come back? And we were like, brilliant, great, the more the merrier. And actually what we're finding with our parent work, particularly with our sort of under 8s and under 12s, you guys as parents are with those children all of the time, the majority of the time. They're either in school or with you. And if we can skill you guys up as parents, then that's going to make a big impact on how the children do. Children feed off us, they feed off our environment. So if we can work all together, and it's a really collaborative approach. So it's not the traditional us versus them. We want to work with you. We want to get alongside you. And this afternoon, I'm going to be actually delivering one of our parent workshops that we do to parents around anxiety, so that it is actually one that we deliver as part of our offer, just to kind of give you a bit of a feel of what we do. Oops, why is that not going on next? So at the beginning I talked about some of our outcomes. So this is the revised child and anxiety depression scale, which is one that we use nationally for any of our increased access to psychological therapies interventions. So the first one is a 9-year-old with low mood and panic. I don't know if you can see the little red line. Anything above that is kind of clinically significant. And you can see this is after 6 sessions with the parents. This is a parent-led intervention, so we work with the mum. And you can see just how much the results have, the scores have dropped. Similarly, the next one was a 12-year-old with anxiety. A little bit of, it wasn't highly significant, but there was enough there for us to kind of go, do you know what, actually, if we intervene now, are we going to prevent this escalating in the future? And again, you can see the scores have massively dropped. And similarly, a 15-year-old with anxiety. There's still a few issues that are a bit higher, but we're below that level of clinical threshold. So I think and the children and parents really like seeing these graphs, because actually visually, it's a really good indication of how far you've come in your sessions. This is an email that we had from a parent a year later. So this little lad was one of our first people through the project, actually. And it said, I'll read it out, but I hope you're well and you don't mind me contacting you. I just wanted to drop you a line to let you know how Ralph is getting on almost a year after we last spoke, and to say a massive thank you for your help. Ralph is doing brilliantly these days, no anxiety about school, and he's even attending breakfast club, which he was really nervous about. But now he's the first in queue. And even better, his dad's now taking him to rugby on a Sunday morning. A few weeks ago, he was so nervous he didn't join in, and now on his 4th time at rugby, 3rd time as the first one didn't count, his dad sent me the touch video. We weren't able to share the video, unfortunately, but it was basically him in the middle, just legging it down to the try line from the 22. I'm so proud of him, and while I don't religiously stick to the techniques we used, I know that we do still use them to an extent with Ralph, and because of this and your help, he's flourishing. This is a year down the line from 6 sessions with this child. So it shows that it's lasting. And also, he will be getting stuff in school as part of our whole school offer. So we've done the one-to-one, but he will also be accessing things like our transition group, friendship groups, mood and mind groups that we also run. So just in terms of what children get referred into, so we did a project where we looked at 2 of our services across the southwest. I'm not sure which 2 it was. It's been kept very secret, squirrel. But it just shows what the referral's coming in for, and anxiety is the biggest. And I think, we're all aware, and why you guys are all here, that anxiety is a massive problem. I think COVID has had a huge impact on that. I think a lot of young people struggle to come back to school. For us, we had a lot of young people who were worried about catching COVID at school and taking it home to their parents, or, because they've heard, mum or dad or gran's been vulnerable and has been shielding. Well, if I go to school, what if I catch it? What if I come home and kill gran with COVID? We had a lot of that. And, these are the things that young people are worrying about. They're not worrying, they're not able to process the adult stuff that we're seeing and rationalise it. They hear COVID kills. They hear Russia are going to bomb the UK. That's what they're worried about, those sorts of things, because they're getting these messages on social media, on the TV and on the news. And their brains aren't at that development point where they can actually process that and know that the risk is actually quite small in that case. They just hear the big picture. So I think, anxiety is a massive thing. And low mood, so lots of kids who are quite, down. And conduct disorder, that's kind of behavioural kind of needs as well. And we do work a bit with self-harm, but again, we've got a pathway up into our specialist services. So if we're working with somebody and they are risky or start engaging in more risky behaviour, then we can pass those along and do that transition across. But differently to here in Ireland, our CAM services work all age, so they work from 0 to 18. So we would just work through that. So just in terms of summary findings, in 2 services in 2021, we had 1,488 referrals between April 2019 and July 21, so that was during COVID. So considering the schools were closed, that's still quite a large number of referrals that were coming in. Just to give a bit of an idea of demographics, 60% of those were female. 12 years was our kind of average age for the referrals, and 80% of those are white young people. South West is a very kind of white area, really. But we do have a lot of other nationalities, so we're working with people with English not as their first language. Average waiting time, so bearing in mind we had our 4-week wait target, was 29 days from referral to being seen for the first time. So that's less than 3 weeks. And the average time spent in the service was 103 days. So that's roughly six to 8 sessions every week for those 8 weeks. So I think that just gives a sense of that, you know, the turnover that we can have. We can see an awful lot of young people using this model that we're then able to do. So 960 young people went through the process at the time we did the deep dive. 75% attended their first appointment and 43% actually completed the course in full. Some young people kind of do 1 or 2 sessions and say, actually, do you know what, it's not for me, as do parents. And that's okay, you know, we're an early help prevention model. We're not dealing with high risk. We're not dealing with, you know, levels of concern. So actually, if a parent or a child says, actually, do you know what, this isn't right for me, then that's absolutely fine. And I think that works really well because we're not telling you that you need to come and see us. We're working with you. It's very collaborative. So I showed you some of the ARCADs early on. 87% of our young people, we get those 2 graphs, which is really, you know, which is massive. I think the national target's something like 80%, so we're above that. And 55% have made a reliable improvement that's long-lasting. So just in terms of achievements, really, 71% of young people have waited less than 4 weeks, which is massive. I think CAMS nationally, it's something like 30%. And 71% of those children, as I say, made an improvement. So I'm a little bit quicker. I waffled.
That's all right.
So yeah, I guess, well, we're going to do questions in a bit anyway, but...
Yeah, we'll do questions this afternoon.
Yeah, I just think it's worth... I'm just going to waffle now without the slides. But I think what we've really seen is that this works, it makes a difference. And the fact that it's a joint initiative with Department of Health and the Department of Education, it's tri-funded. So actually, we're all working together from that side. So it's not us, you know, it's not a health thing, it's not an education thing, it's a joint project. And schools have really bought into it. We're getting phone calls from schools pretty much every day saying, when can we have this service? When can we be part of this? We've heard really good things. Or we've had children move from one school that's got a service to another school that hasn't. Well, why aren't you in this school yet? So the word is getting out there, and I think, you know, we've got a long-term plan that by 2026 we're going to be in every single school in the southwest, which is a massive undertaking. But as I say, by the end of next year, we're going to be in over 50% of the schools within the southwest, which is huge, considering we didn't exist less than sort of 3 years ago. So I think that just shows the expansion and the passion from our commissioners and the health services and NHS England and the education staff to kind of say, actually, this works. It's got its flaws, you know, every service will have its flaws. You know, sometimes there isn't, you know, we can't find the right thing for the young person. So, but we'll try and do something with them so that at least everyone goes away with something, that you're not just left hanging, you're not just left wondering what to do. But as I say, the whole school approach work is key. You know, as part of that, we also do what we call a stop and think session, which is for teachers, and teachers can just book into those slots and have a consultation, almost like a supervision session, where they can bring something they're worried about to us and we'll talk it through them. So, for example, we had one the other week who kind of contacted us and said, look, I'm really struggling with this child in my class. They just wind me up, and I don't know why they wind me up, but they do. And they said, and she said, I'm aware that my responses are not helpful. So we booked them in the session and we talked it through. And actually, now the teacher is aware of what it is that's causing that conflict. and it's because of stuff that was going on in their personal lives, and it was impacting. So by working through that, that teacher is now approaching that child in a different way, and the relationship is much better, and that child is now thriving in the class. As I say, we also offer teacher training sessions as part of inset days. So we've delivered sessions to whole staff teaching groups on anxiety, low mood, signs and symptoms, managing meltdowns in the classroom, all of that. And schools will come up to us and say, do you know, could you do us a workshop on something? And we'll try and find something, or we'll bespoke build something to meet that need. So at the moment, I'm working on a workshop as part of a service improvement plan around self-harm, because actually self-harm is massive, and we're seeing it more and more in primary as well. So actually, if we can deliver something to the education staff to enable them to be able to communicate and talk to the young people better, maybe that will help build those relationships, because actually not all self-harm is a mental health problem. So it's often a form of communication, just as lashing out can be a form of communication. So actually, if we can get them to think of it in a different way, maybe that will impact further down the line and, you know, go on. I mean, I've got hundreds of case examples I could give, because, you know, we've been doing it a while, but I had a girl who was self-harming. School kind of went, oh, God, she's self-harming, must be a mental health thing, you know, she must be depressed. I spoke to her, and what was happening at home was mum was drinking excessively, going out at night. She was looking after 3 siblings, searching for her mum, and she was quite quiet. She didn't know how to say that, so she thought if she cut her arm, somebody might notice and come and say, what's the matter? And instead, no, school just went, oh, pass it over to you. Sat down with her for an hour, spoke to her about it, found that out. We ended up getting early help from social care involved, mum into drug and alcohol services. The self-harm stopped, she felt listened to, and actually the family are now functioning in a much better way. But actually by medicalising that incident, we could have gone down, you know, the psychiatric route, when actually all it was her asking for support and advice, and not knowing how to say to somebody, I'm really struggling. So by doing something, she got noticed, and that was what that was about. So I think, you know, there's loads of things that by working and embedding yourselves in schools as mental health professionals, we're able to pick up and address at that much, much earlier level.
So just in the last few minutes, could you maybe explain, so you've a group, a cluster of schools.
Yes.
So what does that mean in terms of interventions for each schools? How does that get organised?
So it's everyone's individual, because some schools have already got some really good pastoral support and interventions in place. We're not there to replace anything that's already happening. What we're there to do is to work alongside the schools, find out where the gaps are and see where we can offer anything else. We can offer an audit which will highlight some of those gaps. So we've got an audit that we can do with the schools. So some schools we're doing loads and loads of whole class interventions, whereas some other schools we're only doing one-to-one work because they've got a need, because they haven't got any pastoral support in the schools. And some schools just want us for the training, some schools just want us for the consultation. So we don't have a specific, this school gets, you know, you get X amount of time. But what we do is each of our education practitioners are allocated to a school, so they're the link person. So each school has an early help link from social care, each school will have a education mental health practitioner link, and each school will have their designated mental health leads, and those 3 will be communicating and doing that structural kind of oversight. And then anything that needs escalating or is a little bit more complex. So, for example, my link school, because I've still got a clinical caseload, is our pupil referral unit for children who've been excluded or have got additional needs at a level that they can't be managed in mainstream. So I work with that school. I don't need to do the one-to-one support because they're already having support usually from core CAMS, so our specialist CAMS services, social care, etc. It might be under child protection. But what I can do is support the school in developing their skills and managing that from a mental health perspective. So we've done a lot of our workshops and teacher training in there. So yeah, every school is different and it's very needs-led. It's a responsive model. So that's kind of the aim, really.
Okay. Thank you very much. Thank you, Sarah.
Thank you.